Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Azim Fatihi bin Muhammad Azmi. I am from Department of Surgery. So today I would like to share with you the approach of surgical patient in terms of history taking. The management of the surgical disorder require not only the application of the technical skill and the training in the term of basic sciences. However, it needs a genuine sympathy and indeed love for the patient in establish the diagnosis. We, as a doctor, must become an old-fashioned sense, an applied scientist. Sometimes we need to become an engineer, an artist, and minister to establish rapport with our patient. Why? Because the life and or death often depend upon the validity of the surgical decision, and our judgment must be matched by the courage in action and by high degree of technical proficiency. At the first contact, we must gain the patient confidence, and we must convey the assurance that help is available and will be provided. We must demonstrate the concern for the patient as a person who need help, not just a case to be processed. This is not always easy to do, and there are no rule of conduct except to be gentle and considerate. Most patients are eager to like and trust their doctors and respond gratefully to a sympathetic and understanding person. Some doctors are established a confident relationship with the first few words of greetings. For example, Assalamualaikum Pakcik, Hai Pakcik, Pakcik tinggal mana, Pakcik duduk mana, which mean you knock straight away about the disease, but you ask a little bit about background of the patient. It does not matter how is it done, so long as an atmosphere of sympathy, personal interest, and understanding is created. Even under emergency circumstances, this subtle message of sympathetic concern must be conveyed. History taking is a detective work. Preconceived ideas, snap judgment, and hasty conclusion have no place in this process. And the diagnosis must be established by inductive reasoning. You as a doctor must first determine the facts and then search for essential clues, realizing that the patient may conceal the most important symptoms. For example, the passage of the blood in the rectum, in the hope that if it is not specifically inquired about, or if nothing is found to account for it in the physical examination, and it cannot be serious. Some common symptoms of surgical condition require special emphasis in the history taking. Let's go one by one. Pain. Pain is common chief complaint in the surgery. A careful analysis of the nature of pain is one of the most important features of surgical history. You must first ascertain how the pain was begun. Was it explosive in onset, rapid or gradual? Was it precise, the character of the pain? Is it so severe that it cannot be relieved by the medication? Is it constant or intermittent? And sometimes the pain are classic association. For example, pain in appendicitis. Usually, it's a vague pain of the central umbilical and then become localized at the right fossa. Or in the pancreatitis, the patient complains of pain over the epigastric region, which is radiated to the back, and the pain relief while leaning forward. Next, vomiting. you must ask what did patient vomit? Is it gastric content? Is it bilious? Is it blood? How much? You need to quantify, which is you want to know the volume, how often, and then how did the vomiters looks like? Is it projectile? Because it is very important for us to know, which is can lead us to the certain diagnosis. Next, change in bowel habit. A change in bowel habit is a common complaint that is often of no significance. However, when a person who has always had a regular evacuation notice a distinct change in bowel opening, particularly when patient complain of intermittent alternation of constipation or diarrhea. Sometimes you need to ask the patient regarding the size and the shape of stool and any changes in the discharge or blood that coming out from the anus. Or is it patient having tenesmus, which is patient complaining of feeling to urge of bowel opening, however there is no output from the anus. Next, hematemesis or hematuria. Bleeding from any orifice depends on the most critical analysis and can never be dismissed as due to some immediately obvious cause. The most common error is to assume that bleeding from the rectum is attributed to the hemorrhoid. Not all per-rectal bleeding is due to the hemorrhoid, and the character of the blood can be great significance. You must ask whether the blood is clot, is it bright or dark red, or is it coffee ground vomiters, which is indicate of bleeding from the peptic ulcer disease, or patient having melena or dark tarry stool open the bowel opening, because it will give you an idea whether the hematemesis or coffee ground vomiting, which is lead to you the diagnosis of varicose or non-varicose bleeding. Jaundice. Jaundice is a common surgical condition, so you must ask the patient regarding the onset of the jaundice. Is it intermittent or continuous? Because it gives you certain diagnosis. For example, when patient had intermittent jaundice rather than continuous jaundice, maybe this patient have some malignancy such as periampullary tumor because of the nature of the tumor that lead to the intermittent jaundice. Other than that, you must ask any associated symptoms such as abdominal pain, because jaundice with abdominal pain is different from the jaundice without abdominal pain, or we call it painless jaundice or painful jaundice. Other than that, you must ask any associated symptoms such as dark colored urine or any pale colored stool. On top of that, you need to ask any further history that will aid you in getting the diagnosis, such as the precipitating factor for the patient become jaundice, such as high risk behavior, any drug history, or any previous procedure that have been done for the patient. Hematuria. Hematuria is another common surgical condition that you may encounter in the ward. Hematuria is blood that mixed with a urine. So you must ask whether the hematuria is painless or painful, because sometimes all the painful hematuria is indicate benign condition, such as the most common one is due to the stone, which is compared to the painless hematuria, most of it is due to the malignancy. Then you must ask about the color. of the hematuria? Is it fresh blood? Is it mixed with the urine and less bright red? Or is it dark in color? Because it will give you the idea of the origin of the bleeding. On top of that, to aid you to know the location of the bleeding from the genitourinary tract, you must ask the patient, is it the hematuria, is it throughout the urination, or is it at the beginning or in the end of the urination? Other than that, you should ask any changes in urination, which is you must be detailed in getting the symptom of irritative or obstructive lower urinary tract symptoms. Family history. Family history is very important because it gives great significance in a number of surgical conditions. For example, polyposis of the colon is a classic example. Other than that, Peutz-Jeghers syndrome, chronic pancreatitis, multigranular syndromes, and other endocrine abnormality may be associated with a family history. So, acquiring about the family history is very important in surgical disease. Past medical and surgical history. This is a very important component in clinical because you must know the background of the disease of the patient on top of the current situation, because it will give you the assessment of the patient performance status before you embark patient from any procedure or intervention. Other than that, if patient have any previous surgery or procedure that we have done before, it will aid you in establishing diagnosis. For example, patient had history of cholecystectomy before, coming with obstructive jaundice. Possibility this patient might have obstructive jaundice due to the choledocholithiasis, which is stone in the common bile duct. Social history, very important in surgery, because some occupation can lead to the certain disease. For example, in clanton, backtick industrial, using dye, have risk of bladder cancer. High-risk behavior can lead to the hepatoma for the patient. Smoking also have risk of a AAA formation. Take home message. This is my last slide. When you take history for a patient, listen first and listen second. Do not use the closed question. Use the open question. And history taking is an art. The way to acquire this skill, you must keep practice and practice. And last one, the best book is Our Patient. Thank you for your attention.